Okay.
Are we on?
Mm-hmm.
We good? Okay,
Mm-hmm.
so we're going to talk a little bit about mallet fingers and the different types of mallet injuries. So, first of all, when you talk about a mallet injury, you need to understand the anatomy of the extensor mechanism in the finger. So this is a finger up top here that we've drawn. So here's your finger from the side. Okay, a lateral view. We have the fingernail out here. Here's a representation of our DIP flexion crease, and here's our PIP flexion crease. So this is going to be our DIP joint, and here's our PIP joint. And on the top is going to be the extensor mechanism. So here's your extensor mechanism, or extensor tendon that comes down on the back or top of the finger and the dorsum of the finger, and attaches out to the dorsal part of the distal phalanx. Okay, and that's called the terminal tendon. The terminal tendon is here where it attaches to the distal phalanx. And a mallet finger occurs when a hyperflexion injury occurs to the finger. So if you hit the wall and it bends your finger down like that and it forces it down, while your extensor tendon is trying to keep it straight, it forces it down, and either the tendon tears off the bone here, okay, like this, and that's called a soft tissue mallet, or a little portion of the bone will actually chip and remain attached to the tendon, okay, and that's represented down here, and that's called a bony mallet. So a soft tissue mallet here and a bony mallet here. Now when you splint these injuries, because a majority of mallet fingers are treated conservatively without surgery, and we can review surgical indications in a little bit, but a majority of these are treated without surgery. So when you have the injury, you end up with this extensor lag, as you see down in the bottom frame here, or this bottom picture. And so as you can see, as the distal phalanx drops down in flexion, the distance between the attachment of the tendon and where the tendon is increases. And that's what you're trying to minimize. Okay, you're trying to approximate the tendon to its attachment point as close as possible with a splint when you treat these with a splint. So when you put a splint on, whether you put it on the top dorsally or palmarly, there's various ways to make them, but you want to try to approximate the tendon as close to this bony attachment as possible. Or if there's a little bony fragment, you want to try to approximate the main portion of the bone to that little chip of bone as close as possible. And that's why a slight amount of hyperextension usually achieves that most effectively. Okay, so you can stop that part.